So shall we start now today's lecture? I think people not joining. Uh, Let them ask if you have any problem to join the class. Now our today's topic is the uh, dose response relationship of the drug. So as you know, the main aspect of the pharmacology or pharmacodynamic is the dose. Then another one we have already discussed, that is receptors. The third one is the interaction between the drug and receptors, and we have already discussed the various theory of the drug receptor interaction. And now, in this lecture, we are going to study the relationship between the dose given and the response obtained. And this is the very important aspect of the pharmacodynamic. By studying the relationship between the what we can say the dose and response, we can able to understand the so many aspect, quantitative as well as qualitative aspect of the drugs, its efficacy, its potency, its median effective dose, and then median lethal dose. We can plot the curves, we can find the therapeutic margin, we can find the you can say the overall the pharmacodynamic profiles of the drug. So this relationship between dose and response is very important to understand. Now in the general or on average concept, if you look at the pharmacodynamics, then you will find that there is a direct relationship between dose and response, and it is but natural that we can say that there is a direct relationship between the dose and response observed. Now if you see now if you see the dose response relationship, the response to the drug. Now whenever you give any drugs to the patient, the response of the drug in the same patient varies depending upon the dose or amount of the drug given to that particular patient. This is a clear-cut phenomena. If you take the one tablet of the paracetamol, if you take the two tablet of the paracetamol, if you take the three tablet of the paracetamol, you will get the variable response of the drugs or variable therapeutic response. Now, this is the individual study, but if you take the paracetamol and give it to the 1,000 people, again, same dose will produce the variable response. So, it is very complex to understand the relationship between dose response uh, of the drug. Now, drug, you can say the response of the drug, or you can say the result of the drug, or outcome of the drug varies according to the its dosage. That means the magnitude of the drug effect. That means the quantity of the drug effect or intensity of the drug effect depends on the functions of the dose. So there is a direct mathematical relationship between the dose given and the desired therapeutic effect produced. Now, so then already that is, you can see the proportional relationship, that dose is directly proportional to the response. Just to try to understand in this way. So the relationship between this relationship between the doses given and the response produced by the individual is expressed in by graphs. Then this graph is known as dose response relationship curve or dose response curve. Now I will show you the graph. Let me change the page. Here you can see the graph. So what we are taking here on x-axis, we will take the dose. On y-axis, we will take the response. So as the dose increases, hello, 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 हाँ बोलो, हाँ बोलो बोलो. नेव જેવી હશે, नेव 92 જેવી. હા. That is, on x-axis, if you take the different dose, and on y-axis, you take the different response. So as the dose increases, the response increases. So this is, you can say, what we want to study. We want to understand the relationship between the dose and response with the help of the graphical methods. Now, if you plot the dose and if you plot the response in the way I have told you, you will get the two type of the dose response curve. One is graded dose response curve or gradual dose response curve, and another one is the quantal dose response curve. Another one is the quantal dose response curve. Now, graded and quantal, they are the two types of the dose response curve. Number one, the graded dose response curve. In the graded dose response curve, that gives the relationship between dose of the drug and intensity of the response in a single biological unit. That means if you give the different dose of the paracetamol to the single rat at different time interval, you will get the different response. That means here the single for a single human beings is used to study the graded dose response curve. The curve represent level, the response also increase progressively until it reaches a steady level called as ceiling effect. Now here you can see, in the initial phase, if you give the dose, there will be no response. But at this level, you are able to observe the minute response. And as you increase the dose on x-axis, similarly y-axis, there will be increase in the response. And at particular level, the response will be maximum and beyond which, if you increase the dose, if you increase the dose from here, say for example, let me tell you, hmm. So up to this, we started the from 0 milligram and we given the 2 milligrams. Up to 2 milligram, you are not able to observe or any produce response. After that, if you increase the dose, say for example 3 milligram, your response will be 3. 4 milligram, your response will be 3. 5 milligram. That means as you increase the dose, the response is increasing. As you increase the dose, the response is increasing. But the one at the maximum response, say for example, this is a 20 milligram. But if you give the 25 milligram or 30 milligram, there will be no increase in the response. So this response is known as ceiling response or ceiling effect of the drug. Here you can see that is known as ceiling effect or ceiling response. Now, again, let me tell you, here there is a gap. Here you can see this there is a gap. Here you can see, from we will start from the 0 milligram, but up to this we are not able to see any response. Our response will only start when we will give this amount of the drug. So this is known as threshold dose. This is known as threshold dose. Threshold dose. That is the minimum dose which is required to produce the and what is maximum response. The maximum, it is not possible to increase the response by increasing the dose. That is known as ceiling effect, and this is the maximum dose or minimum dose which produce the ceiling effect. So these are the different component of the dose response curve. Is it clear? So how dose response curve is plotted? Number one, you have to give the graded dose response curve. We are talking about the graded dose response curve. Now, in graded dose, what we are giving the different dose to the same individual and measuring the dose response observed at the different doses. So you will get this type of the curve. This is known as graded dose response curve. Now, what are the different component of the graded dose response curve? So it is very easy to understand. It is very easy to understand. What we can say, first one is the threshold dose. If you give the 0 milligram natural, there will be no effect because practically we are not giving the dose. If you slightly increase the dose, then again there will be no effect. Then if you increase the slight dose, then again there will be no effect. When you will observe the effect at threshold dose, when the concentration of the dose or when the amount of the dose reaches to the threshold value, at that time you will able to see the observable response, that is known as threshold dose. Now as you increase the dose, the response will increase. As you increase the dose, the response will increase. The point will come that beyond which it is not possible to increase the dose response. So that response is known as ceiling response or ceiling effect or ceiling response. And the dose which produce the ceiling effect is known as ceiling dose. So these are the different important component of the dose response curve. Now let us see if you modify the unit, or you can say the scale on the x-axis. Say for example, if you convert this dose, here we have simply taken the dose as a 1 milligram, 2 milligram, 5 milligram, 10 milligram, 20 milligram. But if you convert this dose into the log and again you plot the graph, your this curve will be converted into the sigmoid shape. Curve will be converted into the sigmoid shape. So that is known as low semi logarithmic graph of the dose response curve. Why it is semi logarithmic? Because only one axis is square. If you convert both the axes, then it is a logarithmic scale. If you convert the one axis, then it is known as semi logarithmic square. So only for you, you have to remember that on the simple graph paper, the dose response curve is very simple. It is something like hyperbola. When the dose is converted into the log dose, and again, if you plot the same graph by using the log dose on x-axis and response on y-axis, the shape of the hyperbola is converted into the sigmoid shape. So many times the questions will be asked that what is the shape of the graded dose response curve on the semi-logarithmic paper? So it is sigmoid. What is the shape of the dose response curve on simple graph paper? It is hyperbola. Hello, are you getting what I am telling you? So what we can see, the dose response curve, there are two types of the dose graded dose response curves are observed. One is the hyperbola shape, another is the sigmoid shape. In sigmoid shape, it is observed on the semi-logarithmic graph paper. The different component of the dose response curve is threshold dose, then ceiling dose, ceiling effect. So these are known as different component of the graded dose response curve. Now let us try to understand what is written in your book. The graded dose response curve gives the relationship between dose of the drug and intensity of the response in single biological unit. So already I have explained you in the single biological unit, that means one rat, one mice, one guinea pig, one human being, one cattle, one buffalo. If you give the different dose of the same drug, say for example paracetamol, if you have given the 1 milligram, 10 milligram, 20 milligram, 50 milligram and 100 milligram, you will get the different response. Simply you have to measure the response and you have to prepare the graph as shown in the figure. On the x-axis you prepare the plot the dose, on y-axis uh, you plot the response. And if you do like this, then definitely what we can say, you will get the dose response curve. The shape of the dose response curve in the simple graph paper is the hyperbola. But if you convert the dose into the log dose, and again you plot the graph, that is log dose on x-axis and response on y-axis, then the shape will be converted from hyperbola to sigmoid shape. Now, the different component of the dose response curve here, the curve depicts that when the dose exceeds a critical level, the threshold dose, the response also increases. That means the curve depicts that when the dose exceeds the minimum critical level, that is known as threshold dose. Already I have explained you on the paper. The response also increases progressively until it reaches a steadily level called as ceiling effect. That means that if you increase the dose continuously, the response graph will reach to a particular steady level. By increasing the dose further, you cannot able to increase the response. That means there is a plateau. Then there will be no increase in the graph. It remains constant. So that maximum effect or steady effect is known as ceiling effect. Now, threshold dose may be defined as the minimum dose that is required to produce observable response. We have already discussed with the help of the graph paper. The threshold dose may be defined as the minimum dose that is required to produce the observable response. Say, for example, if you give the paracetamol to particular animal starting from 0 milligram, 0.1 milligram, 1 milligram, 10 milligram, 20 milligram, so it's a minimum dose at which you are able to observe the therapeutic effect of that particular drug. So that is known as threshold dose. That means in આપણે ગુજરાતીમાં જઈએ કે ત્યાંથી એ શરૂઆત થાય છે એને threshold dose કહેવાય. બરોબર, ડ્રગની ઇફેક્ટ આપણે જોઈ શકીએ એની જ્યારે શરૂઆત થાય એને આપણે threshold dose કહીએ. The dose that produce the maximum response, dose that produce the ceiling effect is called as ceiling dose. So already we have seen on the graph paper, and may be defined as the amount of the drug that is required to produce a maximum response. Any further increase in the dose will not able to increase the intensity of the response. So what is the definition of the ceiling dose? It is the amount of the drug which produce the maximum effect, maximum therapeutic effect, or maximum intensity, beyond which it is not possible to increase the intensity of the response by increasing the dose. So that is known as ceiling effect or ceiling dose. Now let us go to the another type of the. So the quantal dose response curves. The first, let us try to understand the meaning of the quantal dose response. Now, quantal dose response curve, the word itself, quantum physics you have studied. What is the meaning of the quantum? Quantum means jumping. It will jump from one position to other position. So in the dose response curve, the quantal dose response curve is also known as all or known dose response curve. Now, what it indicates, what it represents, it's nothing but it gives you the percent of the response of the animal to doses of the drug. That means if you give the paracetamol or any drug to groups of the 100 animals, so at particular dose, how many animals responded? At particular dose, if you increase the dose, say for example, at 1 milligram, 10% animal responded. At 2 milligram, 20% animal responded. At 4 milligram, 40% animal responded. At 9 milligram, 70% animal responded. So this type of the study, this type of the relationship between the dose and the person population responded is known as quantal dose response curve. Now here you can see here in the earlier type of the dose response curve, that is the graded dose response curve or graduated dose response curve, we are measuring the intensity of the response in terms of the quantity. Here we are measuring the fraction of the population that is responsive to our doses. So when you are measuring the response of the drug among the population, you are having only two choices: either it has responded or not responded. There you cannot grade that +2 response, +3 response, +4 response. Say for example, somebody is suffering from the fever, and if you give the paracetamol, you can take the temperature at different hours. So you will find that there is a reduction in the fever. You can quantify that data. Similarly, blood pressure, it can quantify with data. But if you ask the one patient whether you have fever, you are cured or not, then answer will be only to either yes or no. So that kind of the effect of the drug is studied among the populations, that is known as control dose response curve. Control dose response curve, that is known as all or none response. That means either all will respond or none will respond. So, and why it is known as jumping? It is known as jumping because there are only two positions: either the animal will respond or it will jump to, or animal will not respond. There is no in between. You can say the any agency or any option is there. So that's why it is known as control dose response curve. Now, each animal receiving a dose is categorized as a responding or not responding. That means already I have told you there are only two options: either animal will respond or animal will not respond. And the population responding to each dose are recorded as a percentage dead or percentage alive or percentage responded or percentage not responded. The relationship is based on all or non phenomena which cannot be quantitatively measured, such as occurrence of the sleep. Now here you will see quantitatively measures such as occurrence of the sleep convulsion images. This control response, when plotted against the log dose, does not show a linear regression. However, the percent response is converted or transferred to the probit. The relationship between linear the graph is sigmoid in shape in both normal and logarithmic graph paper. This type of curve is used for estimating and determining the median effective dose and median lethal dose. Now, the control dose response curve, I think you are very much clear what is control dose response curve in comparison to the graded dose response curve. In control dose response curve, the thing is that what you are doing, you are taking the entire population. What you are doing, you are giving the different dose to the different population or different dose to the particular group of the people in the your experiment. Say for example, you have taken the 10 rates in one group, another 10 rates in second group, another third group, fourth group, fifth group. That 5 groups, 50 animals. In the first group you give the 1 milligram, in the second group you give the 10 milligram, in third group you give the 100 milligram, in fourth 1000 milligram, in fourth 10,000 milligram. So different group will be given different doses. That means the entire population is exposed. In the graded dose response curve, we are giving the dose to the individual animal. At the same time, we are measuring the effect of the on the individual animal. That means in the single biological unit was used. While in case of the control dose response curves, what we are doing, we are giving the dose to the particular group of the populations, and we are measuring the response in only two terms: either responded or not, either live or dead, either cured or not cured. Now, if you collect the data, that means at different dose, you are having the percentage responded and percentage not responded. If you plot the data on the simple graph paper, the curve will be, you can say the sigmoid. If you convert the dose, that means cumulative data. If you convert the dose into log dose, again, the curve will take the shape of the sigmoid form. Sigmoid form. Now, control dose response curves is you can see the is useful in the study of the therapeutic effect of the or pharmacodynamics of the drugs effect, where it is not possible to measure the drug effect quantitatively. Say for example, occurrence of the sleep, then convulsions, then emesis. These are the phenomena where you cannot grade, you cannot measure uh, what is the intensity of the emesis, or what is the intensity of the sleep, or what is the intensity of the convulsion. It's very difficult to measure. Hmm? So in such cases, in such the drugs which produce such kind of the therapeutic effect, it is very useful. This control dose response curve is very useful for evaluating this kind of the drug. Now, if you see why we should study the control dose response curve. First thing to know the margin of safety of any drug, to compare the potency of the drug, and to compare the efficacy of the drug. So these are the three major objectives to study the control dose response curve. Or somebody asks you the question, what are the objectives of the control dose response curve? Then you should able to reply in this way, that they are used for the studying, or for they are used for to study the margin of safety of the drug, to compare the potency of the drug, and to compare the efficacy of the drug. Now, what is the what do you mean by margin of safety? What do you mean by potency of the drug? And what do you mean by efficacy of the drug? Let us try to understand first three words, these words, and then we will see how this dose response relationship is able to, you can say, the measure the effect. Now, if you see this thing, then definitely it will take the, you can say, the, you will have to understand the your important aspect, especially what we can say. Just a minute, let me. Your important aspect of the pharmacokinetic or and pharmacodynamic relationship. Median effective dose. It is symbolically represented as a ED50. Here it is given ED50. Now, median effective dose is a statistical quantity. First, you take in your mind, it's a median of all effective dose studies. So it's not absolute quantity, it is a statistically derived quantity, just like average, how we are counting. Similarly, you can also calculate the median effective dose. That is ED50. Now, median effective dose, what is median effective dose? So it's amount of the drug that would be expected to produce, a desired therapeutic response in the 50% of the population exposed to the that particular drug. Now try to understand. Suppose you have given the paracetamol to 100 rats, or a group of the 100 rats, and out of that, if 50% of animal will respond, then your dose is known as median effective dose. It's a very simple definition. The dose which produces the desired therapeutic response in 50% of the animal exposed are known as median effective dose. That is ED50. Now, the similar definition is the median lethal dose, that is used mostly for the toxicological purpose. Median lethal dose, again, it is a statistical quantity, it is statistically derived dose. It can be defined as the quantity of the drugs, or you can say the dose of the drugs that produce the 50% mortality in the population exposed to that particular drug. That means if you give the, you can say, the higher dose of the paracetamol to 100 individual rats or mice or animal, Apu Vijay? That is known as median lethal dose. That means the effective dose and lethal dose. What is different? One is meant for, one represent the therapeutic effect, another represent the mortality. One is used for the study of the beneficial effect of the drug, another is used for the lethal effect of the drugs. Now, median effective dose, that means the 50% individual animals છે એને તમે સાજા કરી દો, તો એ ડોઝ ને તમારે મીડિયન ઇફેક્ટિવ ડોઝ કહેવાય. એવી જ રીતે મીડિયન લિથલ ડોઝ છે, 50% એનિમલ ને એ ડોઝ આપો અને 50% એનિમલ જો મરી જાય, that is known as median lethal dose. Now, ED50 and LD50 is the base of the pharmacology. Why? One represent the therapeutic effect and another represent the lethal effect. So whenever you are producing any drugs, you need to find out the median effective dose as well as median lethal dose. Now, ED50 and LD50 indicates what? It indicates the therapeutic as well as toxic potency of the drug. That means they are known as indices of the drug toxicity. One represent, or they are they are indirectly indicates what is their indirectly indicate they are indirectly indicate either the toxic potency of the drug or therapeutic potency of the drug. If you see the definition of the ED50, that is median effective dose, it clear cut indicates the capacity of the drug to produce the beneficial or therapeutic effect. If you see the definitions of the median lethal dose, that it clearly represents the potency of the drug to produce the toxicity, or it clearly indicates the toxic potential of particular drug. Now, now if you see now this therapeutic efficacy or all this thing, that means why we need to study the AD50 and LD50? Because based on the ED50 and LD50, you can classify, you can categorize the drug as well as toxic substance. Say for example, drug can be classified into the less effective, moderately effective, most effective. Similarly, toxic substance can be classified as a less toxic, more toxic, most toxic, highly toxic, moderately toxic. So you can categorize all the drugs, all the toxic chemicals into the different group: category 1, category 2, category 3, category 4, category 4. Similarly, drug can be categorized into the group of the most effective, least effective, moderately effective. So this is the importance of the LD50 and ED50. Now, measure of the safety. Now, this measure of the safety or indices of the safety or safety indices, that it is nothing but the different types of the statistically derived parameters after analysis of the dose response curve. They are known as measure of safety. The first one is the therapeutic index. Now, as the given here, it is a ratio between the it is a ratio of LD50 to ED50. That means it is the LD50 divided by ED50, then that the value is known as therapeutic index. Now, higher the value of this ratio or wider the therapeutic ratio, safer is the drug. Say for example, drug A is having the therapeutic index of 10 and drug B is having the therapeutic index of 1. So how you interpret or what you interpret? If the therapeutic index is 1, that means LD50 and AD50 is equal. So that drug is not at all having any beneficial effect. We should not try to use this kind of the drug, because as soon as you give the dose, 50% chances are there the animal will die. That is the meaning of the therapeutic index. And similarly, if you look to the drug A, which is having the therapeutic index value 10, that means LD50 divided by ED50 is 10. LD50 is equal to 10 into ED50. That means you can give the therapeutic dose. If you give the 10 times of the therapeutic dose, the chances of the mortality in the patient is 50%. So it is having wider margin of the safety. You are having the wider margin of the clinical dose. If you give the ED50 or 2 times of the ED50 or 3 times of ED50, it will not produce any mortality. So just to understand that wider the therapeutic index, safer is the drug. As the value of the therapeutic index is greater, your drug will be more and more safe. Now, anti-cancer drugs and anesthetic index is very narrow, very narrow, especially for the anesthetic. And because of that reasons, the anesthesiology super specialization branch in the medical science as well as in the veterinary science has emerged. Because the anesthetic, they're in very, you can say the 1.2 or 1.5 or 1.6. So if you give the by mistake a slightly higher dose of anesthetic, then definitely it will lead to the very serious, or you can say the consequences, or there may be loss of the life, or there may be death of the patient. So because of these reasons, the anti-neoplastic medicines as well as anesthetic medicines require super specialized approach in the human medicine as well as in the veterinary medicine. Now, therapeutic ratio. Now, again, it's the same, nothing. It's a ratio, as they indicate. It's a ratio. It gives a more precise margin of the safety, as in the control dose response curve, the portion between 16 to 84% is more linear in nature. So therapeutic ratio is nothing but it's a LD25 divided by ED75, and ideal value of the therapeutic ratio is 4. Bold, Hers, Jani. Okay, so this is a more safer index. It's a more precise margin of the safety. That means LD25 and ED75. LD25 is divided by ED75. That means the ideal value of the therapeutic ratio is 4. If you put the LD25 by ED75 is equal to 4, that means LD25 is equal to 4 into ED75. ટોક્સિક ડોઝ છે એ 25% મોર્ટાલિટી પ્રોડ્યુસ કરે અને ઇફેક્ટિવ ડોઝ છે 75% એનિમલમાં સારી ઇફેક્ટ કરે. એ બંનેનો જે રેશિયો છે એને આપણે થેરાપ્યુટિક રેશિયો કહીએ છીએ. નાઉ ધ સ્ટાન્ડર્ડ સેફ્ટી માર્જિન. The standard safety margin is the ratio between LD1 to ED99 or LD.1 to ED99.9. The drug safety could be better expressed by using the ratio derived from the two extreme of the, or you can say the standard safety margin. It's nothing but the LD1 divided by ED99, LD.1 divided by 90. That means we are reducing the chances of the lethal effect from 50% to 25%, and from 25% to 1%, or from 1% to 0.1%. And at the same time, we are increasing the chances of the therapeutic beneficial effect from 50% to 75% to 90% to 99%. So LD1 divided by ED99, that means the dose which produce the mortality in only and only one animal, or which produce the 1% mortality, to the dose which produce the you can say the beneficial therapeutic effect in 99%. So the ratio of this quantity of the dose is known as standard safety margin. The drug safety could be better expressed by using the ratio derived from two extremes of the respective controlled response curve. Now, and because of these reasons, it is considered as very useful. Then certain safety margin, CSF, it represents the dose effective in 99% out of 100 or 999 out of 1000. So this is the formula of the CFS. Simply you are supposed to remember the formula of different measures of the safety. There may be, you can say, the question like write a short note on the measure of the safety or therapeutic indices, or the different parameters of the measures of the safety. So there you are supposed to write down the these definitions as well as in the formula. Now let us discuss the different terms which are used for the to describe or to understand and to explain the dose response curve. The first one is the potency. Potency, it's nothing but the dose required to produce the you can say the desired therapeutic effect. Say for example, if you will take the examples of the paracetamol. If somebody is suffering from the fever, then we will determine that if this much temperatures will drop, then it is okay. So let us define first that the drop in the 2 degrees centigrade is very much required to produce the therapeutic effect. So the dose which reduce the body temperature by 2 degrees centigrade, that is you can say the optimum therapeutic effect. So what is the potency? It's a dose which is required to produce the desired or predetermined therapeutic effect. Already, with the help of the examples, you can better understand. Say for example, somebody is suffering from the fever. and we want to drop the body temperature by 2 degrees centigrade. So we are giving the dose, different dose. If the one dose will drop the 2 degree centigrade drop in the body temperature, then that dose is known as potency of the drug. Now the potency and safety have no any relationship. That means if drug is potent, then it is safe. It is not like that. If drug is safe, then it may be potent. Now it's not like, they are not at all related at all. Highly potent drug may be highly toxic. Highly potent drug may be least toxic. Highly toxic drug may be least potent. Lowly potent drug may be highly toxic. So there is no any definite relationship between the potency and safety. They are totally unrelated. One is concerned with the therapeutic effect, another is concerned with the toxic effect. So you cannot find any relationship that if potency increase then safety decrease, if potency decrease then safety increase, or potency is there is a exponential or any mathematical relationship between the potency and safety. It's not like that. So there is no any relationship between potency and safety. Potency and dose, and they are inversely related. It's very clear to understand that potency of the and dose, they are inversely related. That means if the dose decreases, potency increases. If the dose increases, potency decreases. So it is very easy to understand. What is the definitions of the potency? It's a dose which is required to produce the desired therapeutic effect. એ ડોઝ જેટલો નાનો હશે એટલી પોટેન્સી ડ્રગ ને સારી કહેવાય. Say for example, we are having the drug A and we are having the drug B. Now A produces the desired therapeutic effect at 10 milligram and drug B produces the desired therapeutic effect at 1 milligram. So what we can say, which one is more potent? Drug B is more potent. Why? Only small amount of the dose is required. So B is more potent than A. This is the first statement. Another statement is B is 10 times more potent than drug A, because the 1 milligram of the B produce the equal response when the 10 milligram of the A. So the potency and dose, they are inversely related. That means if you increase the dose, potency will decrease. If you decrease the dose, potency will increase. That we'll try to understand with the help of the dose response curve in the later part of the discussion. Now, potency, it's a relative term. It is not used isolated. Again, it's a relative term. In potency defined or it is decided in relation to the desired therapeutic effect. You have to identify the predetermined effect. So if you change the predetermined effect or desired therapeutic effect, your potency will change. Say for example, we have seen that drop in the 2 degrees centigrade in the body temperature, the dose will be considered as a potency. But if our desired therapeutic response is 4 degrees centigrade, then potency will change. So it's a relative parameter. It's not absolute value. Again, it is a calculated. It is a relative. It is dependent on or other parameters. So it's not an absolute term. And there may be comparison to the drugs, or potency is always measured in comparison to the other drug. That drugs are known as standard drug or reference drug. Say for example, morphine at the dose rate of 0.2 milligram per kilogram and hydromorphine at 2.0 milligram per kilogram produce the same response. Then you can say the hydromorphine. That means the more, what is the reference and what is the standard, that we will try to understand. How potency is measured? Say for example, I say this drug is, you must have the you can say the reference drug or standard drug with which you can compare the potency of unknown drug. You are knowing the system internationals of the different unit, kilogram, all these things. So similarly here the reference standard is there. Say for example, morphine is a reference drug. The potency of the morphine is always you have to compare with the other drug. So here morphine 0.2 milligram and hydromorphine 2.00 milligram produce the same response. So which one is more potent? Naturally morphine. Why? Small, 10 times less drug is used to produce the morphine, while hydromorphine uses the 2 milligram. So this is the less potent. And you can say the morphine is, or you can say the hydromorphine is 1/10 potent than the morphine. So potency is a relative term. It is always measured in comparison to the reference or standard substance. Higher the dose, lower is the potency. Lower the dose, higher is the potency. The comparison between two drugs will always in reference to the standard substance or reference substance. Another one is the latent period or latency. It is the you can say time interval between the terminations of the administration of the drug and time at which the desired therapeutic response is observed. Now, again, it's a time interval between termination of administration of the drug and the time at which the desired therapeutic response is observed. Now its value is shorter in case of the IV. તમે જેવું ડ્રગ નું એડમિનિસ્ટ્રેશન સ્ટોપ કરો અને પેશન્ટ ને થેરાપેટિક ઇફેક્ટ જોવા મળે, એ બે વચ્ચેનો જે ટાઈમ ઇન્ટરવલ છે એને લેટન્ટ પીરિયડ અથવા તો લેટન્સી કહેવાય છે. આ પીરિયડ એટલે તમે દવા આપવાનું બંધ કરો અને સીધું થેરાપેટિક ઇફેક્ટ જોવા મળે. તો if you give the intravenous injection, then the latent period is the shortest. Latent period will be shortest, and it is longest after you can say the extravascular route like oral route, intramuscular route. So it's a very easy to understand. Now duration of action, it's a time interval during which the drug continuously maintains the desired therapeutic response. It is a duration of, it's a interval of the time, or it's a period during which the drug continuously maintains the desired therapeutic effect. The value of the, or you can say the length of the duration of actions depends on the route of the administration. The duration of action is very short subcutaneous. Onset of actions, already all these things we have already discussed in the previous class. It's the interval between the administration of the drug and appearance of the its first sign of drug action. Reserve receptors. So what is reserve receptor? What is receptors? Already we have discussed four types of the receptor, drug receptor interaction. Now these reserve receptors are the excess of the drug receptors that are required for maximum response of the drug. Now you just try to understand what is there in that things. In the reserve receptors, just a minute, let me check. Now, the reserve receptors are the excess of the drug receptors that are required for maximal response of the drug. Reserve receptors are also known as spare receptors. Now, the reserve name itself indicates they are excess of the drug receptors that are required for maximal response of the drug. And reserve receptors are nothing but they are known as spare receptors. Now, silent or inert receptors. Silent or inert receptors are receptive substance are the receptors are the receptive substance which the drug bind but do not produce any effect. Example is the plasma protein. So silent or inert receptor. Plasma proteins are also known as silent receptors. Why? Because the with plasma protein drug binds but it is not able to produce any pharmacological effect. But in fact it is pharmacologically remains inactive. So these kinds of the substance which are present in the blood, which are present in the body, they are known as silent or inert receptors. The name itself indicates that by binding with inert or silent receptors, drug will is not able to produce any pharmacological or therapeutic effect. Then orphan receptors discovered that they are known as orphan receptors. So this is the, you can say, the terminology of the pharmacodynamic. Now, tachyphylaxis. Tachyphylaxis is a phenomena in which the effect of the drug diminishes when it is given continuously or repeatedly. This phenomena often develops in course of the few minutes Example, effect of the repeated administration of the tyramine on blood pressure. Tachyphylaxis is also termed as a desensitization. Just a minute. Tachyphylaxis. So, what is tachyphylaxis? Tachyphylaxis is nothing but if you continuously take the drugs, small amount, the day will come that you will not find any pharmacological benefits or any pharmacological effect. That means the pharmacological response will get diminished continuously. So what happens that to produce the pharmacological response, you will take again more and more amount of the drug. Especially this is true for the psychotropic substance. Say for example, somebody is having habit of the taking sleeping pills containing the diazepam. So what happens that in initial period they will take the one tablet. They will get very you can say the peaceful sleep. But after 1 week, there will be no effect of the one pill of the diazepam. So what they will do? They will take the one full tablet and one half tablet, so 1.5 tablet. So that again it will come continue for the 1 week. They will get everything is okay. But after 15 days of the starting the medicine, again 1.5 tablet will not produce any effect. So they will increase to two. They will increase to three, four, four. So this will lead to the addiction. This will lead to the tachyphylaxis. This will lead to the dependence. And why this happens? The tachyphylaxis. What is tachyphylaxis? It is nothing but the diminished response of the drug when the drug is continuously given. This phenomena often develop in the course of this tachyphylaxis. There may the time may be minutes, or it may be hours, or it may be days, or it may be months, or it may be years. So this is known as the tachyphylaxis or desensitization. Then tolerance. Then the tolerance. Now, tolerance is a gradual decrease in the responsiveness to a drug. It requires days to week to develop. Example, tolerance to alcohol. Now, tolerance is nothing but it's a again same thing like tachyphylaxis. If you increase the dose continuously, then the response to the drug will get decreased. Gradual decrease in the response of the drug, and the tolerance will develop within week, within month, or within year. Say, for example, tolerance to alcohol. If you take the alcohol 10 ml today, tomorrow you will need the 20 ml. On the next day, you will need the 40 ml. On next day, you will need the 50 ml. So that is known as tolerance. That is known as tolerance. Then refractoriness, that means loss of the therapeutic efficacy, is known as refractoriness to the blood. Say, for example, you continuously keep on taking the alcohol, then you will not find any you can say the effect of the alcohol. That means you become refractory to the alcohol. Huge amount of alcohol will not able to produce any signs and symptoms in you. જેમ કહે છે ને વધારે દારૂ પીતા જાય એક સમય એવો આવશે કે દારૂની અસર જ નહીં થાય. So that is known as refractoriness, and all these phenomena, whatever you are seeing, that is tachyphylaxis, tolerance, refractoriness, drug resistance, all is due to the change in the dynamics between the drug receptor interaction. Now, what are the reasons of the tachyphylaxis, tolerance, or refractoriness may be developed because of the following receptor. First thing is the change in the receptors, then loss or down regulations of the receptors, then exhaustion of the mediator, or there is you can say the depleted source of the mediators, then increased metabolic degradation due to induction of microsomal enzyme, physiological adaptation. These are the possible reasons for the tachyphylaxis, for the tolerance, for the refractoriness. There may be change in the configuration of the receptors because receptors are proteins in their expression. The DNA plays the important role. So DNA may change the expressions of the proteins, and drug is not able to bind with that particular receptor. So they are not able to produce the beneficial therapeutic effect. So you feel that I'm not able to get the desired therapeutic effect. So you will continue to increase more quantity of the drug day after day. Similarly, there may be down regulations of the receptors. That means if you continuously give the drug, the population of the receptor will get reduced. That is known as down regulation. So these are the possible reasons uh, for the what we can say tachyphylaxis, tolerance, and all these things. Now, Now drug resistance. What is drug resistance? Already we are knowing the what we can say the this antimicrobial resistance. So in antimicrobial, what happens that if you give the drugs, bacteria has nothing to do. That your drugs is not able to kill the bacteria, it is not able to inhibit the bacteria. Bacteria will multiply without any effect of the antibiotic. That is known as drug resistance. So loss of the effectiveness of the antimicrobial drug is known as drug resistance. So this is, you can see the different terminology. Now additive. Now when you give the two drugs combinedly, then chances are, say for example, you have given the drug A and drug B. So what happens that in drug A and drug B, when you give it to combine, there are three possible ways. Number one, drug A, the therapeutic effect of drug A and therapeutic effect of drug B will be summed up. That means 1 plus 1 is equal to 2. Another possibility is there, 1 plus 1 is equal to greater than 2. That is known as synergism. Additive effect, that is known as summation effect. Synergism, that is known as increasing or 1 plus 1 is greater than 2. બંનેના સરવાળા કરતા તમને વધારે ઇફેક્ટ જોવા મળે તો that is known as synergism. Then potentiation is also there. So let us try to understand. If the pharmacological effect of two drugs, that is A and B, given together is quantitatively equivalent to sum of individual expected effect, that is therapeutic effect of drug 1 and therapeutic effect of drug 2 when administered alone. This phenomena is called as additive effect or summation. Very simple to understand. When તમે બે drug ભેગા આપો, drug A અને B, ત્યારે તમને જે therapeutic effect જોવા મળે કરો, પછી drug A એકલું આપો, therapeutic effect measure કરો, drug B એકલું આપો, therapeutic effect measure કરો. A અને B ની ઇન્ડિવિડ્યુઅલ ઇફેક્ટ નો સરવાળો જો કોમ્બિનેશન ના સરવાળા બરોબર હોય તો તમે એવું કહી શકો કે this drug and A and B will produce the additive effect when they are given concurrently or when they are given at a time or when they are given in combinations, and such drugs effect is known as additive effect or summation. The such drug generally shares the same mechanism or mode of action. That means આપણે કહીએ છીએ ને કે જાજા ત્રણિયામાં એક કામ કરતો હોય બે કામ કરે, બરોબર? બે કામ કરે તો અડધા દિવસમાં પતી જાય, એક કામ કરતો હોય તો આખો દિવસ થાય. So this is something like nothing but the summative effect. Examples of the summative or additive effect are very common example is the ephedrine and aminophylline. Both will act on the bronchial muscles and both will produce the relaxations of the bronchial muscles, and because of that reasons they will help us to dilate the uh, bronchial muscles, especially in case of the asthma. Then another one is the streptomycins and dihydrostreptomycin as a antibacterial. So that one this is another example. Then the next one is the synergism. What is synergism? If the pharmacological effect of two drugs administered together is quantitatively greater than. So here it is very easy to understand. Don't look to the fashionable words and all these things. A plus B is greater than, or AB, when you give the both the drugs in combination, their therapeutic effect is greater than their individual therapeutic effect or their sum of their individual therapeutic effect, then it is known as synergism. Synergism, very clear cut in mathematically you can explain 1 plus 1 is equal to or is greater than 2 or 1 plus 1 is equal to 11. It's mental concept. બે માણસો ભેગા થાય તો બે કરતા વધારે નહીં 22 જણાનું કામ કરે અને synergism. So, if the pharmacological effect of two drugs administered together quantitatively greater than that is explainable on the basis of the simple summation of their individual effect is called as synergism. Now, potentiation. When the effect of one drug is considerably or remarkably increased due to the concurrent administration of another drug. એક ડ્રગ છે એને તમે બીજા સાથે આપો તો એક ડ્રગ એકલું આપો ત્યારે એની ઇફેક્ટ બિલકુલ નથી આવતો, તો બિલકુલ લો છે, પણ એને બીજા ડ્રગ સાથે આપો ત્યારે એની જે ફાર્માકોલોજીકલ ઇફેક્ટ છે એકદમ વધી જાય અથવા એકદમ બેનિફિટ કરે, તેને શું કહેવાય? પોટેન્શિએશન. વન ડ્રગ ઇઝ ગિવિંગ ઇઝ ઇન્ક્રીઝિંગ ધી પોટેન્સી ઓફ અધર ડ્રગ્સ. Best example is potentiations of the sulfonamide, potentiation of the penicillin, then potentiations of the acetylcholine by physostigmine. So you will find lot of examples because the presence of the other drugs will increase the potency of another drug. There are many examples in the pharmacology. Then another one is the target tissue or target organ. Therapeutic effect, placebo, already we have studied. So this is all about the pharmacodynamics. Now let me show you some graphs so that you can be able to understand the basic concept of the potency and all these things. If it is available with me, yes. Okay. Let me check the PPT. Yes. So are you able to see? Let me change. Instead of sharing the screen, I have to share the window. So now you are able to see the graph, I think so. Okay. Let me give you the full view. Now, in this graph, you see the ED50, that is the dose at which gives the response or effect on 50% of exposed population, that is known as ED50. So here you can see this is the dose and this is the response. So here by plotting this line, you are able to calculate the ED50. Now, this is the response, this is the dose, and we have given the 10 milligram, 20 milligram, 30 milligram, 40 milligram, 50 milligram, 60 milligram, 70 milligram, 80 milligram, 90 milligram, 100 milligram. Okay. Now here you can see if you give this is the effective code. This is the you can say the ED50. We have converted the dose into the log dose form, so the shape of the curves will be like this. Be like this. Now, again, if you increase the dose like that, you'll find the curve like this. So here you will find that here there will be you can say the initiations of the therapeutic effect. So that is threshold dose for the effective therapeutic effect. And here, if you increase the dose up to 60 or 70, there will be initiations of the toxic effect. toxic effect. And if you increase the dose, slowly toxic effect will increase, and it will become statum. So this is known as death curve. This is known as pharmacological or effect curve. And this is the, you can say, the therapeutic window. So in this way, you can say the log dose response curve can be obtained, or it can be concluded. Now let us start again the same thing. Entire screen. Just a minute. Wait. Let us see the factor affecting the what we can say, the modifying the drug actions or the drug doses, or factor modifying the drug response, dose drug response. So in fact, this is very simple factors, and already we have discussed the doses or doses regimen, then dose rate. So these are the factors which produce the variations in the dose response, or that produce the variations in the drug effect. Now you see the species, the physiological factors which are responsible for causing the which are modifying the dose response of the species. The same drug may produce the different degree of the response qualitatively and quantitatively in the different species. Say for example, the morphine is a one drug which produces the CNS excitations in the cat, while in other species it causes the sedation. So this is the examples of the species difference in the modifications of the pharmacological response. Another example is the atropine. If it is consumed by the rabbit, then there will be no toxicity, because the stomach of the rabbit produce the enzyme atropinase, and because of this atropinase, and the atropine is hydrolyzed, and it will produce no therapeutic or no beneficial effect on the or sorry, no toxic effect on the rabbit. But if the same atropine is consumed by the other animals, it will produce the toxicity. Another example is the cat is highly susceptible to the aspirin toxicity due to deficiency of the glucuronidase transferase. Already we have discussed while discussing the metabolism of the drug that cats are deficient in the glucuronidation. Similarly, dogs are deficient in the acetylations. So they are, the sulfonamide drugs are more toxic in the drug. Another factor is the age. Very young and very old and men and animals require the low dose already, because the very young, very neonates, very newborn animals, their hepatic microbial enzyme system is not so mature and functional. So if you expose these individuals to particular dose, then definitely there will be more toxic effect. Similarly, because of the young older age, there is a loss of the hepatic efficiency, a loss of the hepatic functions. So in such animals, in such you can say the people, in such group of the people, that is in pediatrics as well as in the geriatrics, the dose should, you have to lower the dose, because they are more prone to toxic. Gender variation, that male and females, because their entire endocrine profiles, their entire physiological profiles is different from each other. In the female reproductive tract is dynamic, it is cyclical, there is a cyclical phenomena of the hormone release, and we have already studied. So because of that dynamic physiology of the reproductive tract, the dose response in the male and female is always different. It is also true for the men and women. For example, red squirrel is more toxic in the female as compared to the male rats. Body weights, dose of the drug is calculated on the basis of the body weights. If variation in the body weight is very high, then there is a variation in the dose will always be there, and because of that variation in dose response curve is always there. Say for example, during the pregnancy, there is an increase in the relative body weight of the mother. If there is a dehydration, then there is a decrease in the body weight. If there is edema, then there is increase in the body weight. So these are the pathological condition which is able to changes the body weight of the patients. And while giving the drugs to such patient, you should consider the doses of the drug, you should consider the effect of the drugs. Then genetic factors is always there in any kind of the physiology or biology. In certain species, the certain breeds, they are highly specific, highly sensitive to the toxic effect of the particular drug. Say, for example, ivermectin, it is practically non-toxic to cattle and buffalo uh, and most of the breeds of the dog. But in the coolie breed of the dog, they are highly susceptible. And if you give the ivermectin to this coolie breed of the drug, definitely it will produce the toxic effect and mortality. Then our pathological effect, already we have discussed the disease of the liver, kidney, lungs, they will produce gastrointestinal drug, will alters the metabolism, excretion, absorption, and distribution of the drugs. And because of these factors, there is a change in the dose response, and then you have to adjust the doses regimen. Then environmental factor, then temperature, humidity, dietary factors. Already we have discussed while discussing the absorption that if your diet contains the positive cations, then these they will interact with the fluoroquinolones, they will interact with the oxytetracyclines and form the insoluble complex, and such insoluble complex are not available for the absorption, so their viability is reduced. Similarly, there are certain drugs which in the presence of the fat they get absorbed very rapidly and to great extent. So combinations of the fat and fat soluble drugs are also useful to increase the absorption. Similarly, vitamin C and copper iron increase the iron absorption by reducing the ferrous for, and all these things that we have already discussed in the lab. Then therapeutic factors, pharmaceutical factors, resolution time, disintegration time. Then already we have discussed different formulations of the drugs and all these things. So this is all about the pharmacodynamic and pharmacokinetic. And now onwards, the another part of the pharmacology will be discussed by the Vaidhi Madam and Dr. Ratandeep Singh from next day onwards. We are moving as per our classes, and I hope that very few students have joined. What is the problem? I can't understand. So anybody can, now you can switch on your camera and mic. No problem. Hello, please. Hello.
Yes, sir.
Okay. So this pharmacokinetic, pharmacodynamic is over. Now systemic pharmacology, as well as you can say the neuropharmacology, will be taken further by Dr. Vaidhi Madam and Dr. Ratandeep sir. Let us see if something is left in our pharmacology, and then it will be more. બાકી રહી જાય છે કઈ થોડું ડિટેલમાં ભણાવવાની ઈચ્છા ઘણી પણ બોર્ડ ને એના વગર ફાવતું નથી હવે. હેલો. મૌનિક.
Yes, sir.
મજા આવી? વોઇસ બોઇસ ક્લિયરિટી ક્લિયરિટી બધું વ્યવસ્થિત હતું કે કઈ તકલીફ થતી હતી?
હા સર, બધું ક્લિયર જ હતું, ઓકે હતું.
ક્લિયર હતું ને? બસ બસ બસ. ઘણા લોકો જોઈન નથી થયા, આપણે એટેન્ડન્સ લઈ લઈએ. જસ્ટ અ મિનિટ. I will also put this lecture on the YouTube so that you will able to do it yourself also as and when it is required for you. Let me check the course curriculum. History workbook course outline. Okay. So in the course outline, if you see, then application window, course outline, Chrome tab. Here you can see the introduction we have discussed, history finished, then source, nature already discussed, principles, that is kinetic, dynamic, dose response relationship. Today we have discussed the different terminology. Today we have discussed the factor modifying the drug effect and doses, drug acting on. So this first unit is over now. Tomorrow onwards, or from Monday onward, Dr. Ratandeep Singh and Dr. Vaidhi Medan will start drug acting on autonomic nervous systems and drug acting on the central nervous system. So both will take the lectures parallelly, one lecture of autonomic nervous systems and another lectures on the central nervous system, because we have to finish this work at early, you can say the start, because in your first hourly there should be general pharmacology and autonomic pharmacology and CNS pharmacology must be completed. Otherwise, it will be very tough to cover. Okay. So, any questions regarding? And those who have not joined, please kindly tell them they should join. They should join. Now, I will take the attendance. Mehul Solanki,
Yes, sir.
Modi Forum, Fel Arpit,
Yes, sir.
won't be able to listen me?
Sir, voice is unclear.
Voice નથી આવતો. Okay. Uh-huh. Okay, again I will take. No problem. Modi Forum, no problem. Do it. I have already downloaded the Excel sheet and I can see how many students are present for how many times, including minutes and whether they have left or not. So that I will see. Many of you people are having the poor coverage. I am able to see your network and all these things, especially Manish Solanki. Are you able to listen me?
Yes, sir.
Yes, good. Because again, ultimately, it also depends on the quality of the network. Those who are sitting in the big cities, they are having very good coverage. Those who are sitting in the rural area, definitely, but obvious, they will have to face the problem. Okay, so we'll stop here. Thank you for attending the lectures. We have spent more than 1 month. તો સેમેસ્ટર ક્યારે ચાલુ થયું હતું? નથી ખબર. Okay, thank you. We'll finish the class.